All right, we may as well go ahead and get started. My name is Luke Haynes. I'm with Haynes Physical Therapy, and I want to present today a webinar version of a workshop that we have on rotator cuff and shoulder pain problems due to the COVID-19 and the social distancing and all the things that we're going through as a community, as a nation, as the world. Instead of a live workshop format where this is typically done, and we can have a little bit more participation, I still want to have that information out for everybody. And so this may actually give you a little bit better choice or opportunity to see some of the graphics and information that I have to display. So why don't we just jump right into it? So the first question that I normally am going to ask of folks who show up is, has anybody had shoulder pain in the last 30 days? I'm an owner of a couple of shoulders that have had some issues myself, so I could raise my hand as well on that because I definitely have had shoulder pain. And so obviously if you're paying attention and tuning in, that you probably will fall into that category as well. So let's talk about what is the rotator cuff. And let me pull up my laser pointer. So what is the rotator cuff and what bones are involved? Well, there are really three bones that are involved, and we'll just walk through them. The first of the bones is the upper arm or the humerus. The second one is the shoulder blade or the scapula. And then the third is the clavicle or the collarbone. Now, one thing that gets important, especially with dealing with the shoulder and rotator cuff, is right at the edge of the shoulder blade, the point that sits right out here on the edge is what we call the acromion. And as we discussed, that will become a little bit more important a little bit later. Of note, the shoulder itself is it is the most mobile joint in the body, partly because there is only one place where this entire upper extremity, from the hand all the way to the shoulder, there's only one bone that attaches that entire extremity to the body, and that's actually the end of the collarbone right here, and where it attaches in the middle onto the sternum. So a very mobile joint. So, and speaking of the joint, let's talk about what type of a joint we have. So on the upper arm or the humerus, we have a shape of a ball. The area in green there indicates the part that makes contact with the shoulder blade, and it's a ball. And on the shoulder blade itself, it's basically got a nice little socket. And so ultimately this is called a ball and socket joint. And so the curious thing about the shoulder in relation to, say, the hip down in the lower extremity, so in the hip, we've got a big, deep socket. It's like a big coffee cup, if you will. And then the ball of the upper leg sits right in there, very snug. So it's a very compact joint. In the shoulder, the ball, the best analogy is it is a golf ball sitting on a golf tee. So we've got a lot of surface area, potential surface area, but very little in the joint itself. So that's one of the things that really makes the shoulder joint so mobile and what lets us move that thing around so well. And so let's talk a little bit about the muscles of the rotator cuff. For basic muscles, there's a lot more musculature that's involved. However, the main muscle that tends to get, you don't have to remember these names, but the main muscle that tends to get involved is the upper of the rotator cuff, and it's called the supraspinatus. The next one below it, and these all attach on the back side on the shoulder blade, is what we call the infraspinatus. There's a smaller muscle right below that. It's called the teres minor. It's not involved with rotator cuff problems very often. It can be from time to time, but it does meet the criteria to be off of the shoulder blade and attached to the upper arm, so it gets included as well. So that's the third. The fourth muscle of the rotator cuff actually sits on the front side of the shoulder blade up against the rib cage, and it actually attaches onto the front. So you can see it attaches right here onto the front. So sometimes if you're dealing with some pain in the front of the shoulder, it very well could be this subscapularis. So we call those the sits muscles based on the first letter of their name, and that's basically the muscle group that comprises the rotator cuff. And so let's talk about the things that have to work together for the shoulder, the rotator cuff to function. Um, Whenever we deal with a problem with the shoulder, we definitely have to look just a little bit beyond just that shoulder joint itself, the muscles of the neck that attach from the shoulder and attach over onto the neck become very critical, as well as the collarbone itself, the shoulder blade, and then the rib cage. So there are four very key issues that if we don't look at the mechanics and the function of all four pieces, then we probably are going to be missing a good bit of the true problem going on with the shoulder. If I'm treating a shoulder and just not making that progress, I may have realized that I've forgotten maybe to look at the neck or to look at the collarbone or maybe look at the first rib especially. From time to time, we have an issue with the shoulder blade itself, that mechanically something's not working right. And so definitely it takes all four pieces to get a good outcome when dealing with the shoulder. And so normally when I have a workshop, a live workshop, I hand out all of my participants a little worksheet that has a lot of questions for them to answer. And it's a fun, interactive way to go through the process. I don't have the handout to hand to you today since you're just watching this on your phone or your computer. So I'll just run through the questions, and it's just a summary of what we just talked about a little bit. So what is the rotator cuff? The first question, it is a group of four muscles that move the shoulder. The second question, the shoulder is a ball and socket joint. And then the four areas that have to work together for proper shoulder movement is the neck, the collarbone, the shoulder blade, and the rib cage. Okay. Normally, at this point, what I'll do is what I call a little 5-minute miracle. So let me talk a little bit about the 3 stages of healing. When somebody comes to see me as a patient with, and it doesn't matter if it's a shoulder problem, if it's a neck problem, if it's a hip, a knee and ankle problem, there are 3 phases of healing that we have to look at. The first phase is we have to, number one, knock down pain, knock down inflammation. So there's going to be a mechanical issue somewhere along the line that's been created, but a person comes to see me because they're in pain. You go see your doctor not because you have a mechanical abnormality. You normally go to see the doctor because of the pain that's associated with it. So the stage 1 is we want to deal with pain, inflammation, get that knocked down to a tolerable level. Then we can move on to phase 2, which phase 2 is then restoring that mechanical issue that we talked about being problematic, restoring motion and restoring strength. And those usually go hand in hand on dealing with that phase 2. And then the third phase is getting a person back to normal with their daily activities, whether that's going for a daily walk, whether it's going to work out on a consistent basis, whether that's playing with the grandkids, whatever that looks like for you. That is the third phase of putting all those pieces together of decreased pain in phase 1, increased strength, mobility, and mechanics in phase 2 to let you then put together the whole package for phase 3. So normally when I'm looking at this 5-minute miracle, what I'm looking at is just one of the tricks that we have, one of the things that we can do to have a sudden, quick onset of relief of pain. I frequently will say that decreasing pain that's the easy part. We usually can find some mechanical issue. We can make a change to that in some form or another and get that pain part down consistently. And so that's what the 5-minute miracle is about. What the rest of this workshop is about is what you do to complete that whole strategy. And that has to be that second and third phase of treatment. So can't do really a good 5-minute miracle. I guess I could do some magic on myself. However, I'm not symptomatic right now, so I think we'll just move on from that piece. So how did I come to specialize in shoulder and rotator cuff problems? Well, mine is through experience. So my first experience with shoulder issues, I was in 1985 high school football. I had a situation where another player landed on top of me, dislocated, excuse me, and I don't remember now if it was the right shoulder first or this other left shoulder, but dislocated one shoulder. I went over to the sideline. They reduced it back in, went back in on the next play, and the very next play, same thing happened. Somebody landed on the other shoulder. So very early on at 16, 17, I experienced shoulder problems. Fast forward 20 years. And then all of a sudden those shoulder problems became more of an issue for me. Full disclosure, I have had surgery on the right one. I was a bad patient. I re-injured it because I'm a therapist, which means I'm very smart and I know how to take care of it, which means I did not do those things and I caused more problems. However, since then, that is really what helped me learn how to really take care of a shoulder, is in my own personal experience with those. So my educational background, I got my bachelor's degree, my physical therapy degree from Texas Tech in 1994. In 2012, I completed my doctoral of PT through MGH Institute in Boston. I have what my achievements, among others, some that I'm fairly proud of is I'm the author of the Haynes Method of Neuromuscular Dry Needling. I use dry needling quite extensively whenever we're trying to achieve that phase 1 of decreasing pain. We don't have to do it with everybody. Some people are very phobic of dry needling, but it can be very effective. I use it on me to manage my symptoms. And so I had that trademarked through the U.S. Patent Trademark Office, and I'm the senior instructor for the dry needling, the professional training series throughout the state of Texas, and we host some online training as well with that. Also, I'm a guest collegiate lecturer from time to time as I'm asked. Clinically, I've treated or supervised over 500,000 patient treatments in my 26 plus years here. I've dry needled over 30,000 patients with well over 150,000 different needle applications during that time. So let's talk a little bit about getting back to normal and the first steps. Thing that we always are curious about as therapists is, can we reproduce that pain? So every pain in the body that we deal with, and especially if it's musculoskeletal in nature, if there is a pain, there is some movement that can reproduce that. If it's the shoulder, it could be reaching back, it could be reaching across or up or down. But throughout the body, there's something that is going to reproduce that pain. And that's what clinically, that's what we want to look for and find is what can we do to reproduce that? And the reason for that is if we can reduce it, then we can probably, if we can reproduce it, we can probably reduce it. So traditional physical therapy, some numbers here. We talked a little bit about those 4 areas to treat: the neck, the collarbone, the shoulder blade, the rib cage. Traditional physical therapy in the past, well, and even a lot of places, even still today, are still doing the traditional approach where we just focus on the shoulder and the muscles in around the shoulder and so forth. Using traditional physical therapy, 25% of folks were treated successfully without surgery. And I'll say even my own approach up until about 8 years ago would follow this. Another 25%, they just did poorly. Didn't really get good benefit. So that was kind of a 50-50 trade-off there. Some really good stuff, some patients that really didn't respond to anything. Then there was another 50% that, they did okay. They felt like they might still need surgery, so they went through the process of therapy, but we really didn't get where we needed to. And so that really is what traditional physical therapy in the past, and again, even those clinicians who are still not treating all 4 different phases look like today. So as I've moved forward and started treating all 4 areas, again, the neck, the collarbone, shoulder blade, the first rib especially, in the spine, then all of a sudden we see a significantly different outcome with our patients. So in that case, we really have seen a bump of a change of about 90% of patients can be treated successfully without surgery. And we'll talk about this a little bit. I still have tears in my rotator cuff. I don't frequently deal with pain. From time to time, I may have a little twinge, but I can manage my symptoms, which is what we want to teach you how to do. I can manage my symptoms and still live with the tears that I have and not have to go through surgery again. I'll never pitch for the Texas Rangers or the Houston Astros, but I wasn't going to do that anyway, so I'm not worried about that. But I can do everything I need to in my functional activities throughout my day as a therapist and with anything else that I need to do. There are still 10% of the people that probably will still need to have surgery. Some tears are significant to the point that it just can't be managed without surgery. So if you're watching this, the question is, are you part of that 90%? Are you part of that 10%? So again, back to my reproducible situation. That is what I look for. Can we reproduce that pain? Can we find that motion? And with that motion is a mechanical issue that we're usually dealing with. And if we can reproduce it, there's hope. Because if it's reproducible, we can get rid of the pro, and then it should be reducible. And I apologize for my playing around with the wordplay there. But that is the thing. If we can reproduce it, then we should be able to reduce that pain down and get your function back. So back to the worksheet that you actually don't have in your hands. The third question, if your pain, numbness, or tingling is reproducible, then it is reducible. And so let's also talk a little bit about past 30 days. We asked this in the very beginning. The worst pain I've had was, I'll say for myself, and we use the 0 to 10 scale. 0 is no pain, 10 is your worst imaginable. When I'm dealing with my shoulders, I've had a pretty good month. I don't think my shoulders have given me more than maybe a 1 or a 2 out of 10. There are times, again, I'm a human being, so I don't always do my exercises. I don't always do the things that I should do. So there are times when that shoulder pain may jump up to a 3 or a 4. Because I do keep a close eye on it, I don't let it get to a point beyond that. Again, I'll come to that first phase of healing, and I will knock that acute pain down rapidly so that we can get on to the phase 2 and phase 3. So for me, the past 30 days, worst pain I've had is, I'm going to call it a 2 out of 10. So we want to think about what we were doing when we did have that pain. For me, mine is usually, and sometimes it's when I sleep, because I tend to be a person that sleeps with their head laying on their arm, kind of like that, which if you have a shoulder issue, that's a horrible way to sleep, and we'll talk about that in just a little bit. For me, it's usually a combination of reaching overhead and then reaching back. That's what really tends to irritate mine, and that's part of the reason I'll never be a professional pitcher. But for other people, it could be lifting. It could be getting the milk from the refrigerator, putting a hand in your back pocket. For ladies, putting on the bra, especially shoulder issues for female, that putting on the bra is a big complication. And then fixing your hair, getting your hands up to do that, or getting up and down from the floor. That can be challenging. But you all will have your own issues with your shoulders of what causes that. So I encourage you to think through your daily activities and think about what it is that you're doing whenever you start to have that pain. And again, if it's reproducible, then there's a cause, and there's hope, because we can usually elicit a change. And so just a brief little side route here, talking about the cause of a problem, and this can be any problem. The things to do when faced with that problem. Well, they're really just 3 things. We can ignore it, and I'm going to use a pothole analogy. I live on the west side of town, and I think we tend to get forgotten sometimes when it comes to road repair. And so there's potholes in the road. If you ignore them, well, they're only going to get worse. And when dealing with the shoulder pain, I mean, you can ignore it and it may get better. Usually it's going to require something else, but that's the number one thing that we do, is we just ignore it. The second thing is we can alter it. And so in that case, on the pothole analogy, we can fill it with asphalt. Trucks can come around, they can throw a few shovelfuls of asphalt in there, and they can tamp it down. But we all know if you get a rain too soon, or if there's too much driving on that, within time that pothole is going to flush out again, and you're still left with that same problem. So we're just altering it. We're really not addressing it. This analogy is where we talk about drugs, injections, and surgery. So drugs and injections can help decrease that pain. And that's great. We do want, and surgery as well, we want to change that pain level. However, what it doesn't do is tend to address the mechanical issue that's going on. Again, we talked about 4 areas that have to be dealt with: the neck, the collarbone, the shoulder blade, and the rib cage. Surgery is not going to deal with all of those issues, nor are the drugs and injections. So we're skipping by altering it. Yes, we knock pain down surely, but inevitably that piece comes back. And so really what we have to do is to handle it. Excuse me. So to handle it in my pothole analogy, really the only way to fix that road is just to repave the thing. And so when we're talking about the rotator cuff, there really the best way is just to get natural treatment and learn to manage your own symptoms. And with that is looking at, again, those 3 phases of healing. Getting rid of the pain and inflammation, number 1. And the second one is restoring motion and strength. And number 3 is getting back to those normal activities that you want to be doing in the first place. So back to our worksheet, things to do when faced with a problem. The single biggest mistake shoulder pain sufferers make is number 1, they ignore it. And then the three things that you can do for it, again, you can ignore it or you can alter it. And what I would recommend is that you handle it. So let's jump into the 3 main causes of shoulder pain. And just a quick discussion of imaging and what normal looks like. A very good surgeon friend of mine told me a long time ago, and this is very true, we don't treat a picture, we treat a patient. And so we have to be cautious when we look at imaging because yes, it may show a structural issue, but the question is that structural issue causing your pain? And so just a quick x-ray, here you see the collarbone coming over. It attaches onto the sternum, the chest plate right here. And then it comes over and attaches to the shoulder blade of the scapula here. And then you have the upper arm bone right there. And then out to the side, you see that edge that we talked about, the acromion. In this picture, you see a nice amount of space in between the ball and the socket here, so that everything looks really good there. What that image doesn't tell us anything is about the muscles, the ligaments, the cartilage that makes up the socket itself. So that's what normal looks like. So on this conversation of imaging, a lot of folks. So if we look at the MRI studies of adults who have no shoulder pain, and they'll show that 20% have partial rotator cuff tears, and a full 15% have full thickness tears. And people that are 60 or older, a full half that have no shoulder pain whatsoever have rotator cuff tears on their MRI, and they didn't even know about it. We look at professional baseball pitchers. 40% of them had partial or full thickness rotator cuff tears, and yet they played without pain and remained pain-free even 5 years after they did this study. So the translation, the take-home issue here is, if your imaging shows a rotator cuff tear, that you don't panic. It's not necessarily associated with rotator cuff pain or with shoulder pain. I treat lots of patients who come in and their surgeon, their doctor looks, they see tears on the MRI, and they want to try some therapy to see if they can avoid surgery. As a person who's gone through shoulder surgery, if at all you can avoid having not just rotator cuff surgery, but if you can avoid surgery at all, you really want to, because if you can restore function, decrease pain, and get back to your normal activities, that's the whole idea. And so then we talk about our vomit and our barf. So what is vomit? Vomit is victim of modern imaging technology and the brainless application of radiologic findings. And so it's the treatment based on imaging findings alone without any clinical correlation. Again, we treat the patient, we don't treat the picture. And so you have to be very cautious. You want to make sure that your clinician, your physician, your orthopedist is very well prepared to let you try alternative treatment approaches other than surgery, if at all it can be done safely. Again, we can live with some wear and tear on this body. As we saw, a lot of people have tears and they really don't even know about it because it's not causing them any pain and any problem. So the 3 main causes of shoulder pain. The very first one we'll look at, a patient comes to me, the first thing I'm going to look at is any neck issue. So here we're looking at things such as stenosis, arthritis, degenerative disc disease. With stenosis, we start losing height. We start getting compression on the nerves that come out of the neck. And we're going to look at a couple of different scenarios here. So on the left is a diagram and an x-ray of just looking straight on at a person. So you're looking straight through the face at them. And so one of the issues whenever this disc does start to lose height, and if we start having some arthritis, which these little weird little triangle things in between the vertebra and the disc, we'll call those bone spurs. And so what tends to happen is they can compress onto this nerve that's going to come out of the neck here and then come down into the shoulder itself. So losing disc height in the neck can create a lot of the issues that we deal with in the shoulder, and it's more of a neck issue. When we look at it from this picture, looking at it from the side, not only do we have the issue of the nerves coming out to the side, but if it gets too tight or there's some bulging, herniation of the disc itself, then we can start losing or getting some pressure on the spinal cord itself, and that can result in shoulder issues. So thing number one is we have to look at is the neck and what's going on there. With that, we also look at the rib cage because it's so close to the neck, and specifically the first rib. Whenever I have a patient or one of these workshops, one of the things that I look for is somebody that's having a neck issue and specifically a first rib issue that can be causing issues out into the shoulder, because those are super easy to do a little treatment on and get that 5-minute miracle. So what tends to happen, especially if we're some of these folks like myself who tend to sleep over on their arm, well, we spend a good bit of the night that way, and that first rib actually pops up in here like a bucket handle. And so that changes the space in between the neck and the shoulder, and specifically between that first rib and the collarbone, where all of those nerves that comprise the sensory apparatus of the upper extremity, and it decreases that. So we really, first off, want to look at what's going on with that first rib. A lot of folks get a lot of tension, little tenderness up here in this area. And in some cases, that's related to the spine. More often, it's related to that first rib because it sits right underneath there. And so that's the next piece that we look at in the neck. And so just from a diagram standpoint, that first rib sits, as you can see, right here coming off of the neck. The challenge is if it's sitting up too high, the nerves that comprise, we call it the brachial plexus. It's just the group of nerves that supplies the arm. If there's an issue, a stiffness, a tightness issue between the first rib and the collarbone, then it compresses on those nerves and you get that shooting issue. So the neck and that first rib become incredibly important in our initial approach to treatment. And so also with the neck, we have to look at limited range of motion. So there's 3 planes of movement. First is just your flexion and extension, which is just your up and down. There's rotation, looking side to side. And then there's side bending, which is ear to shoulder, left and right, like that. So we want to make sure that we have the right amount of movement there. And if we're not seeing that in the neck, then that tells us there should be something that we need to deal with there. The second major cause of shoulder pain is impingement. And this is usually a pretty big one. Whenever we're dealing with small tears or tears in the rotator cuff, if there's been a fall, inevitably we're dealing with impingement. So what does impingement really mean? On the picture on the left of your screen, this upper muscle of the rotator cuff, as you can see, it sits and comes underneath this acromion we talked about, and then it attaches out onto the upper arm. Well, we've got these 2 little structures right here are what we call bursa. And so there is a very limited space, and I'm going to move over to the picture on the right. There is a very limited amount of space between this upper arm and this bony structure there. Well, sitting right in that area is that rotator cuff. And this is the rotator cuff muscle that tends to be torn or damaged more frequently than any of the others. And so if we get pain in this area, number one, we're going to see the tissues of the muscle itself. They're going to swell, they're going to get inflamed. And we're also going to see the bursa, which is just a cushion. we're going to see that bursa get inflamed and it's going to expand. So all of a sudden, we have a lot of potential structures that need to be in here to protect that shoulder, but everything is inflamed, everything is swollen, and so all of a sudden, that muscle gets impinged or pinched between the ball of the upper arm and the acromion, the edge of the shoulder blade. And so that's the limitation that tends to give us the biggest problem whenever we're trying to move. With that person that has impingement tends to do this sort of movement whenever they're trying to lift their shoulder up. And so just a good telltale sign of some impingement. These folks tend to have trouble reaching behind their back. They side sleep on the raised arm. And again, here the space gets very small. There's bone spurs and fraying of the tendon that can lead to a tear. So where the collarbone right here comes over and attaches to the acromion or the shoulder blade, very common problem to have bone spurs that develop, and they 99 times out of 100, they're gonna permeate down towards that muscle right there. So with time, that can even lead to some tearing because it's almost going to act like a saw as that bone spur sits down in that muscle. You move around, and it can almost saw that. Now, if you have a fall, it can definitely even pinch or cut that muscle. So bone spurs can be an issue there, and a big telltale sign of impingement. And the third problem causing shoulder pain is poor posture. Every patient that comes in that we're dealing with problems with the shoulder, inevitably, they're going to have an issue with posture. And I normally do a demonstration, so I'm going to describe this for you in just a second. But when we look at this posture, we talk about this forward head thing. Now, as we all spend time on our smartphones or playing on our computers or whatever we're doing, a normal posture, the head is going to weigh 10 to 12 pounds. And that's the amount of force that exerts down through the seventh vertebra of the neck. Neck has 7 vertebrae, and that's how much force is exerted there. As you can see, the further forward that our head goes, it moves from 10 to 12 pounds, or if we're have really poor posture, it can get all the way up to 60 pounds of pressure on that. And the bad thing there is that just leads to degeneration in the cervical vertebra and the discs in that area. And again, the problem is we know that neck issues also create problems out in the shoulders. And so posture becomes incredibly important. But, and I want you to do this. I'm going to turn to the side just a little bit. So whenever we sit nice and tall, see if you can still see it. We sit nice and tall. I want you to try it with this good erect posture. I want you to try lifting your arms up just like this. Okay, piece of cake. Now what I want you to do is to slump down. Drop your head down, slump like a teenager. And then I want you to try the same thing. You'll notice it won't go near as far. And that's all about the mechanics. So just simple posture creates a significant change in rotator cuff and shoulder function. So posture, although it's a very simple thing, is incredibly important for maintaining health and function and strength of the shoulder. So back to the worksheet, the top 3 common causes of shoulder pain. Number 1, it's a neck problem. The second one is impingement out in the shoulder itself. And the third piece is posture. And so what does successful natural treatment look like? In my live workshops, I will normally find somebody who's been dealing with some shoulder issues and go through some of the hands-on treatment that we do, both with the neck, the first rib, the shoulder blade, the muscles out in the shoulder itself. Obviously on the webinar, I don't have a live patient here because we're social distancing and so forth. Thank you, COVID. So what I'll just describe this. What you need to have is some hands-on PT to move the shoulder and the surrounding joints. If you're seeing somebody for some therapy right now, or trying to take care of itself, and your pain is staying elevated, it's almost impossible to get through that first phase of healing, of decreasing that significant pain elevation without some sort of a hands-on treatment approach. So you might want to think about that and take a look what's happening with you if that's happening. The second piece is if we have to do the stretching and the strengthening exercises to retrain muscle memory. So over time, and most of us tend to put up with shoulder pain and issues for a while, we're going to see an adaptive shortening of the muscles, of the ligaments, of the tendons. And we have to both get that length back, and then we have to get the strength back into that. So it's one thing to do the things to reduce pain. But if we don't address the flexibility and the strength of those muscles and those tissues and those structures, then we're going to be right back with that elevated pain again. And then the last thing, I mentioned the dry needling earlier. So in my opinion, the one way to really address significant pain elevation, and I'm going to partly lump this into the hands-on approach because this is where we really see that, is odds are you're going to need somebody who can either use a class 4 laser or dry needling to break that pain cycle. If your pain is staying low, a 4, something like that, odds are you may not need that. But a lot of the people that I see are coming in pain up around 6, 7, 8, 9, and we have to do something to get through that pain cycle first. And dry needling and the class 4 laser, which the class 4 laser fairly recently has been made available to us on humans. Previously, it was restricted to just use through veterinary applications. And so that's been a big plus on us being able to really break that pain cycle, those two components there. And so really that's what successful natural treatment looks like. So what is my offer? I want to talk a little bit about a free consultation that I only offer to my workshop attendees. Now this isn't live and you're just watching it on video, but I'll still honor this. So the free consultation, what you get on a free consultation is we're going to look at certain movements. We're going to feel your shoulder to determine what might be causing your rotator cuff and your shoulder pain. We want to find out if there's something that can be done to heal it naturally. I'll give you some tips. At the end, if you decide you want my help, then so be it. But I'm not going to try to force you to do it or try to sell you on it. Really, the goal is to give you information on what's going on and what you can do to handle it. So let's talk a little bit about the difference between a free consultation and a full PT evaluation. So a free consultation, I mean, it's really that. We're going to take about 15, 20 minutes. We're going to see if we can determine a potential cause, and we're going to see what successful treatment might look like. And then you're just going to get my recommendations on that. If you've been dealing with the shoulder issue for a while anyway, odds are you do need to do that third thing. You need to handle it. And so here we're going to take 45 to 60 minutes or however long it takes. We're going to identify the cause, whether it's a neck issue, a shoulder blade issue, a first rib issue, a collarbone issue. We're going to figure out what's going on there. And then we're actually going to apply successful treatment to that. Then I'll sit down with you and we're actually going to plan out a care of treatment. Now, a lot of folks, myself included, we're human beings. We want an instant fix. And we can knock pain down quite rapidly. We're actually pretty good at that. But that's just a third of the problem. What you have to do is then go to step 2, step 3 of healing, and that is changing the flexibility, changing the strength issue, and then returning those things back to your normal daily activities. And that's the part that tends to take a little bit longer. So quite honestly, it really does take 3 to 4 weeks of consistent treatment to get you where you can fully manage your symptoms by yourself. So I do have, and whenever you see this, I will have slots available for a free consultation and slots open for physical therapy evaluations. If you would like to do that, this was originally done through a webinar. If you'd like to do that, you can, information is down here. You can email, you can go to our website, you can call, or you can just message whatever medium you're watching this in, you can message us there, and we'll be glad to reach out to you and address that and see what we can do for you. But if you have any questions, feel free to reach out to us, and I hope to hear from you soon.